So just letting you know that it's a complicated topic. Sometimes to go back and get out our notes and recap the meeting, it's helpful to have that on recording. So we turn that on now. I just wanted to, remind folks, I think there's been a lot of correspondence. I know that we've sent out to try to keep folks up to speed on our process with this data warehouse effort. And so this is really the culminating meeting of the work of a subset of clinics, both some of your executive director colleagues and other staff at the health centers, particularly a lot of IT folks, to come together and work with our consultant, Roger Chaufournier, to come up with a set of recommendations for the whole to consider to move forward a data warehouse strategy. So today we've got a good amount of time to review those, talk through them, and our very capable consultant Roger's going to lead us through that. So Roger, why don't you go ahead and take it away.
Great. Well, good morning to everyone virtual and to those in the room. Just as a point of clarification and reassurance for the group here in the room, I woke up with some sniffles this morning, and I think they're allergy related. It's not infectious, and it's not a cocaine habit. So just to clarify that. And then another, just a whimsical thing. My daughter is applying to colleges, and she called this morning. She had an interview yesterday with Tulane, and we had moved a few years ago to a very rural community. And they asked her, why do you want to go to Tulane? And she says, well, I've been traveling this single lane road, and I'm ready for Tulane. So I thought, that is quick. Very good. Very quick.
I predicted mission.
So you can reuse that for any friends applying to Tulane in the future. That's great. Anyway. So I had the honor of supporting this sprint, really, over the last 10, 12 weeks to help think through the issues associated with some data warehousing, the decision points, if you will, which really kind of morphed into a larger issue of data strategy. And that was really, I think, my recommendation that it's not just about a particular technology, but there's a series of issues in the environment, both political, strategic, and then tactical issues in terms of how you're going to work together and use the data. So Laura had contacted me earlier this summer and said, are you available? We have this very tight deadline we'd like to meet in terms of helping us sort through these issues. We have a group that would like to come together. It was stimulated by the members of OPCA. And we're trying to think through the data needs and how to best process the data. And we have some decision points specific with OCHIN that we're trying to resolve. So I had the pleasure of both being here face-to-face and virtually over the last period of time, really working almost on a bi-weekly pacing with the group to try to systematically walk through these issues. So today is really the culmination of that process. The endpoint and objective, I think, for today is to try to reach a consensus on either moving forward with the proposed strategy or whatever other fallout there may be, with, I think, the goal that if things were to move forward, that this would culminate in a final presentation in January to the board as part of your normal process. So we'll talk through that. Doesn't necessarily mean that any of the strategies have to wait to January, but it just that would be your normal, I think, cycle for what some of the items that are proposed. So we're going to back up a little bit today and talk again about the why and what are the burning platform needs for a data strategy, a data warehouse to support all your efforts. I think there's a lot of variation in the environment in terms of where people are, in investments that have already been made, in infrastructure that's been built. In some cases, there are organizations that are very mature and have their own data platforms and are working with their CCOs on local strategies. In other cases, the infrastructure is pretty modest, and the bandwidth is not there to really take on a lot of additional opportunities. So we have to take all of that into account, and the strategy was designed to be able to bring that whole environment along, if you will, as we think through the issues. So we could turn to the agenda. We'll talk through the why. We'll then review the recommendations, try to put a context around the recommendations. There was a fairly thick packet that was sent out. Some of you that had trouble reading or sleeping probably used it at night to facilitate that process. But we're going to try to make it as simple as possible today and break it down into manageable chunks that hopefully we can process. And then we'll go through the recommendations systematically and see what adjustments or clarification is needed to put you in a position to comfort to reach a consensus. So go to the next slide, please. Oh, I got the best. Okay, perfect. I can drive. Yep. Okay. So let's talk about why is a big data strategy needed at this point in time. I think the stimulus for this initiative came from probably two perspectives. One is from the OPCA's perspective with the state. Given all of the work that Oregon has done with your alternative payment model and in turn your alternative care model that you have been putting in place, that is resulting in some exciting work, I think, in the field. I know I've had a chance to work with Gil's group in the past and have followed their journey in terms of alternative visit types and how they're really changing the care model, being able to be unencumbered from a fee-for-service encounter rate and instead really manage under a more fixed, predictable capitation, if you will. So that's exciting. It puts you at the bleeding edge nationally in terms of where things are, and it is a bleeding edge. It's not a cutting edge. It's painful change for organizations. It's not a slam dunk to suddenly manage under a risk arrangement or under a fixed payment arrangement. Although you could argue that as health centers, you've been doing that for many, many years through your grants and other activities. But it's a different game now. And the game is being raised and more aggressive in terms of those that want to put you at risk for your work. A greater degree of accountability, starting perhaps with small percentages, but growing to larger percentages. So it's all labeled under this value-based reimbursement. Now, I have to tell you, having been in the field for many years and having been in managed care and other aspects, I absolutely did not believe that the reimbursement system would move as fast as it is moving nationally from what we've seen. For CMS to make a commitment that by 2021 that they'll have 80 to 85% of their beneficiaries under a value-based reimbursement is a game changer. And it is rolling out so fast around the country that it is lightning speed. The different types of pilots and demonstrations and activities, both in Medicare, Medicaid, commercial, all sides of the equation, and now grantors, seeing funding agencies saying, great, here's a grant, but you're going to be at risk for part of this grant. You may have to return dollars, you may have to lose dollars, you may be penalized, but we want to see value for what we're producing. We're no longer just going to give out money without tying it to see some outcomes. There's too many competing priorities. We want people to show us that you have the capacity to be able to translate all of this resource into action. So that was one stimulus, and then certainly some of you have been approached by CCOs or already in risk arrangements with some of the CCOs. And that puts pressure on being able to manage more effectively in that environment. The good news is that some of the CCOs are very willing to share the data and are more liberal, and in other cases, they're not. There are CCOs that are withholding the data because data is power, and data gives you the opportunity to be able to manage all of the pieces of the equation. So for some of you, it puts you at risk in terms of being held accountable under a value-based reimbursement formula, but not having the data to be able to manage it. So it's like driving a car without having your dials and knowing what speed you're going and other aspects. So there's also some challenges in that the CCOs, even if they're really willing to share the data, they only have the data for their members. And so when you want to start to look at how can we use data to work with the state to defend the APM and ACM models, it makes it very, very difficult with all the data spread throughout the state and hard to make the case. The issue of, on a national level, of protecting your PPS rate and your current protections under the current acts is also very vulnerable. NAC has done a fabulous job over the years, has gotten bipartisan support, but the environment is very, very different. The consolidation of the healthcare industry is pretty scary. And when hospitals now own the majority of primary care practices in a community and have it all under one umbrella, they have the ability to potentially undercut the health center pretty dramatically. And when health centers come forward and say, yes, but our patients are at higher risk, and we've got more challenge with our patients, and the payer data doesn't support it, it's even more of a challenge. And NAC has had some discussions with national payers who come forward and said, you've been maintaining this case for a long time, but our risk-adjusted data isn't supporting it. It's just not there. That your patients are not as sick as what we see in private practices. Now, lots of reasons for that. A lot of it's doing with coding and how you capture the data at the health center level. And a lot of you have been in environments where that's not been really an issue in the past, and you're the only game in town. And what's the big deal? Well, it's a big deal now, because when they say we're going to start to erode the protections, and then maybe we need to get rid of the health center program and just to come up with a whole different model. And given that the health systems are now really controlling the primary care base. Many of you are working with critical access hospitals. 75% of them are financially strained across the country. So we're seeing a lot of challenges with some of those hospitals. Some cases, FQHCs are taking them over. In other cases, other groups are coming in and taking them over and trying to figure out different models. So it's also a time when groups are very aggressively trying to figure out how to expand their market share nationally, especially the big payers, the top three. They've got to continue to meet their demands, especially if they're publicly traded. How are they going to be able to continue to show growing revenues at a time when we're trying to cut costs and cut revenue? So you do that through acquisitions and starting to roll up. So we're seeing a lot of that consolidation going on, which puts pressure on you in terms of your ability to compete. And to do that, you need data. You need to be able to understand your cost position, how you compare to others in the market, both private practices as well as your other health centers. It's a time when you have to collaborate to compete. Many of you are in competitive situations in your own markets, and that's healthy. But even in that competitive situation, finding that being able to collaborate to raise all boats is an asset that I think has benefited the health center movement over the years, and the strength of the NAC behind you, the strength of OPCA, but it's something that you have to continue. One of the ways to do that is around data, the ability to share the data and use it and learn how to move forward. There are also lots of other aspects of really trying to understand your populations. If you're being held accountable for the asthma indicator and you want to improve the outcomes of the number of kids on inhalers and other potential outcomes, and wouldn't you want to know that you've got a cluster of kids in 2 housing units that have mold and are driving some of the exacerbation of the asthma, rather than beating up on your providers to do better by getting their kids on inhalers? You'd like to be able to see what are the issues and nuances with your population. I facilitated a project in Tulsa, Oklahoma, with 12 competing hospitals, and they were talking about a data warehouse and sharing their data. They did not want to get into that game. They said, no, our patients are our patients, until they started looking at the data and realized that 50% of the patients were going to all 12 hospitals. and they were Medicaid. They were all Medicaid patients. And so half the patients they were sharing, which made them realize they were all vulnerable. These weren't just their captive population, but they were also being suboptimized. The medication-seeking behaviors, the other types of activities that you see. So they didn't know that until they started really looking at the big data and where are patients going. You'd like to know for your patients how self-activated are they? What are some of the social determinant of health issues that you can really make a difference, can influence? You found out, again, being a leader, working with the Prepare tool that you have tested here in Oregon along with others around the country. You're starting to see that identifying data coming out of that information that allows you to start to think about what are the kinds of interventions we can really make a difference, and doing some really great things, some really powerful interventions that are having an impact. So those are a lot of the sort of core issues. Let me see what questions are there about why are we even getting into this right now, and anybody else that would like to talk about sort of the value proposition, the need for the data. Any thoughts or comments, Craig?
Well, the one thing I would add is we just got back from a NAC, Primary Care Association HCCN meeting, and Jim McRae was there, and so I got the chance to kind of meet with him, and one of the things that in his, he's got a good sense of humor that he kept saying was, he goes, there will be more flexibility at the state level. There will be more flexibility at the state level. There will be more flexibility at the state level. You got that right. So what he's saying is the game's going to change, like the 1115 waivers and the 1332 waivers, all those things that can mess with our payment and attach it to the broader payment outside of Medicaid, and the super waivers that combine those two things are going to be fast-tracked. And you better have your value equation identified. I mean, he said both on the health center level, but he also said, PCA level, you better have your ROI identified as we go forward, because all that's going to be on the table. How quickly it gets put on the table is depends on what the state wants to do. So the bargaining chips are getting shoved to the other side of the table pretty rapidly. So we got to be prepared for that, and data can help us with that. So.
Did everybody catch that on the phone? Talking about the shift potentially for block grants and other waivers to the state level. So any comments or questions on the value? Anybody unclear where we're even in this discussion, or the need to move forward with a data strategy at this point?
We talk about risk arrangements, and yeah, we are, some of us, moving into more formal risk arrangements, but in a sense, our payment is also a risk. There's a risk for us in just maintaining our payment for PPS and the ROI on the health center model and all that. And so, reports or evaluations, like the recent one from Optimus or what PSU has done, with patient-centered primary care home, those are the kinds of things that are going to, help make the case for why health centers should, receive the particular payment methodology and speaks to the value of what we're doing. So just a lot of that has been in the control of other people, and so the extent that we can also make that case and monitor and track that internally is put us in a better position.
So again, Gil was just arguing in favor of the need to move forward. I think one of the subtleties in his comments was, as you were starting to move under risk arrangement, it takes time to really work through and understand the use of the data and how to be able to analyze the data and to perfect some of the data sets. And that's something that if you push off too far in the future, you end up having to do a very quick catch-up that puts you at a competitive disadvantage. Any comments on the phone on the why before we plow into the strategy, the recommendations?
This is Carlos. I appreciate Gil's comment, because I think that from my perspective, the rationalization around value-based is an important one. And I think that you're right on in terms of why is it so important for us if we want to maintain the current sort of PPS structure payment. Data and information is critical. However, I do think that from my perspective, TCOs are going to push value-based because, as you mentioned, CMS is going to push the state is going to push the CCOs to be able to sort of never have a contract again that doesn't have a strong value base or a risk arrangement. And I can tell you, I have been in the risk arrangement business for over 20 years, and there is no way that we can compete and understand our value and our potential revenue without some really good, not just data, but good analytical tools that are going to lead you into transforming your system, closing the gaps of care in your patients, and understanding your financial position. So to me, this is more than just the PPS issue.
Yep, well said. So let's move on then and start to make sense of all of the work of the work group and the essence of the recommendations. So on the screen in front of us is a snapshot of the proposed strategic plan, data strategic plan, if you will, and the core elements. And let's walk through. There's a certain logic to the flow and understanding. So the very first piece is, at the end of the day, one of the core elements is getting access to the total cost of care data. This is how you, as health centers, for your patients, not only the primary care cost, but all of the healthcare utilization and cost data associated with your patients, and in the best case, all patients in the state, where you can compare to the private sector and see how you're performing. So you can be doing absolutely fabulous things with the care of your patients, but if your patients are going to other providers in the community that are higher cost, as specialists or lab results or whatever factors, your costs could be much higher, even delivering the best quality care. And you won't know that until you have the total cost of care data. In the Washington, D.C. area, one of the Blue Crosses a few years ago decided to come up with a gold PPO product. And what they did is they cut the lowest performing 20% of providers in the market and cut them out. Based on cost of utilization. You're out of the game. So your patients are all being reassigned now to others in the market. So if you were right at the bubble and found out that you're being cut because you're sending all your patients to a local reference lab, and that lab is the highest cost lab, and those cost differences are putting you over the bubble and locking you out of the market, you probably want to know that for negotiation purposes, right? Or your number of MRI referrals is so high, and the particular provider you're sending to is the highest cost in the market, and therefore it's throwing all of your cost off. Even though you're the most efficient on the primary care side, you probably want to know that. So this really gets to the need for this total cost of care data. Now, this is not a situation unique to Oregon. All across the country, people are talking about trying to get access to it. It is very, very difficult. It is politically charged. There are a lot of people that don't want to share the data. You'll see the data on ACOs coming out of Medicare and CMS has had very mixed results, and predominantly because most of them are run by hospital systems controlling the data, and they don't want 50% of their ER visits cut. They don't want 50% of their admissions cut. They want to protect that base as long as they can. And so they're playing the game to be in the game, but they're controlling it through the data and through their networks. They're underpricing primary care to get market share because they own the practices that can do that. So they can cut out in various groups. So we're starting to see some of the FQHC-owned health plans that have been very well established in many markets losing market share in some cases because they're being undercut by hospital-owned provider systems. that have the primary care base and can offer a network to that payer at a lower cost. And then control the utilization for a period of time, right? Until the others are out of business, and then the rates go up, and it becomes a monopolistic system. So lots of challenges in that arena. So getting access. Now, Oregon is a different environment. You have been much more collaborative than other states in the past, and some of the total cost of care information is flowing. So we know that OCHIN right now is getting claims data from the state for their research portfolio. And so they have access to that data to look at it, but strictly under the guise of research, and those research protocols are pretty tightly controlled. So the state has shown some willingness to be able to share, but it's going to take some political will to be able to go forward. And that means not only Craig working his magic as he's done in the past, and perhaps collaborating with OCHIN and other groups, but I think it also means all of you as leaders having to be on the same sheet of music. There has to be a consistent messaging across the board as naysayers or other stakeholders come and try to pick apart or refute a common strategy. There has to be a common will across the state to say, no, we're going to get into this game. We need to be in this game. There's also implications about...
Can I just kind of interject? Because I think the one thing I've learned through this process, even though I kind of went on sabbatical and came back into it, was even working with Care Oregon, who we all founded, right? They'll give us utilization data, maybe, but cost data is proprietary. And so to listen to this and say, yeah, we can look at utilization and try to control that, but if we don't know cost and the referral, that's the political hump that's even bigger to get over. That seems, I mean, the way you phrase it, of course we got to have it if we're going to be held accountable for it. So it is a big political.
Yeah, I'm sorry. I think I also want to make sure that we don't. There's more a mystery than it really is. Today, I have full claims and cost data from 3 of the CCOs in which I participate. So they have never said to me, I'm not going to give you data. The only one who has said that to me is Family Care. Outside of Family Care, I am receiving a feed of their entire claims data, premiums and costs with every one of the CCOs. And so I think that it is an important process to recognize that the CCOs, it is also in their best interest to be able to share this data because they have to squeeze money out of the premiums. And the more they allow the primary care systems to control that cost, the greater their benefit is. So I just want to put it out there that it is being shared today, and it is being available today, and I'll be happy to show that to anyone who's interested in looking.
So there's 2 pathways. One is through the CCOs and getting them to share, as Carlos suggested, and he's a great case study. 3 out of the 4 are sharing the data. 1 is not. So if you want to be able to have the total data set, it's a challenge. But that is one pathway. And in the end, you may not get 100% of what you want, and that's an important guiding rule to go by. Don't hold the process hostage by not having 100%. Do the best you can, and with that, develop the sophistication and the ability to manage under that arrangement. So the CCOs are one pathway, the state is another. But whatever the pathway, it's going to require strategy, a united front, and a will to move forward and say, let's be aggressive in going after that data. So let's just stop and see what questions that brings up from a political or need perspective. Maybe were you going to say something?
Yeah, I've been trying to think about what is really important on total cost of care and how well we can compete on the OHP side or the Medicaid side. But it occurred to me that maybe an even more important piece would be to have the total cost of care for the uninsured population. Because it's really, my sense is we're going to see a higher uninsured population with more flexibility at the state level. just an assumption I'm making, downside risk, right? And so if that's the case, that's really the pain point that we as a association of health centers can really use to negotiate in the market. So I can't get total cost of care from the CCOs for uninsured patients. So I just think there's a question about that is really probably one of the most important things we could do is try and understand whether someone's on OHP or not, if they're at 100, 125, 150, 200% of poverty, just what that looks like in terms of cost and utilization, because that's what these systems are going to be trying to shed because there's no reimbursement associated with it. So I just want to make sure we don't forget our core mission of uninsured populations.
Other comments? Craig, were you going to say something?
No, yeah, I was just going to say, again, we were talking a lot about value-based pay and the trajectory and what direction, health centers and PCAs need to go and HCCNs. And one of the things that was brought up is, not just that piece about data beyond Medicaid, but also longitudinal data.
Yeah.
So, which data, which patient is yours and how long have they been yours and what does that mean to their cost trajectory and quality trajectory? And even the Bureau of Primary Healthcare is talking about that with MITRE as their data, like they're going to modernize UDS. And so I got the chance to speak to MITRE and say longitudinal stuff matters, right? And if somebody's just coming in for one visit and they're put into our, numerator and denominator, that's not really who we can impact. And so what are we trying to get at and how are we going to use MITRE and UDS modernization to change care and align the data? And that's one big piece of it. And this can get it. We control the data, we can do the cuts that we want.
Right. Yeah, United Healthcare, in conversations with them a few years back, they talked about the churn. Medicaid patients coming off the rolls and they're no longer on their plan and so forth. And they were keeping longitudinal data for exactly Craig's reason. They know these patients end up getting employed for a period of time, then unemployed, and they're back, and they're forth. And they end up a couple years later back as their patients, and they want to be able to have the longitudinal data to be able to manage them long term. So really understanding that broader point. Other comments or questions on the need for a political effort? So what this means moving forward is that Craig and team would start to marshal the forces to begin to approach the state, the CCOs, work with you as members of the board to think through what does that mean from an execution perspective. How can we get going to really advance the ball and see about getting access to the data as one starting point. So that's something we would begin sooner than later and not waiting for end of next year to be able to begin to tackle. It's going to take some time to be able to overcome the hurdles. Any questions with that piece? It's kind of
I just actually have a comment. It's not a question. This is Vanetta for those who are on the phone. This is where we have an opportunity in Oregon with having so many public FQHCs and Multnomah County in particular being so large. We do have a physician that's now part of the commission and she really wants to get into doing some of these things. There's important ballot measure. So we should really be thinking ahead about leveraging the actual big P politics, those folks who run races and have won races to actually help to move this along. And I think now would be a really critical time where we would get some support. And I can't speak for your counties, but I'm quite sure that it's a financial interest for all of the publics to really make sure that they're doing this. So we should think about that as we're developing the strategy.
Gil, you're going to make a comment?
Well, I was just thinking, getting the data is just, half the battle. It's a big part of the battle, but what you do with the data and how you're using it and what systems you have in place, it goes to the analytics and just, goes to how are we transforming the model of care with the data that we receive, and that's actually, I think, going to be the harder part of it. It's like, so what if I know, what my ED utilization and my hospital utilization, what am I going to do about it, and how am I going to, transform, workflows and things to actually address the situation. So, I think that ultimately it's going to be in the interest of the payers to share the data. And we already have a strong stated interest from the state to get that information to us, for managing APM stuff. But then the burden's going to be on us to be, how sophisticated can we be in terms of the use of that data?
That's really well said. And much more relevant for me from you than me. So, thank you for that.
So Gil's going to be my shill in the audience because that takes us to one of the next buckets. So Aaron, we're walking through the kind of discussion on the strategy. So if you look at the fourth bucket, this is talking about furthering your data management analytical capacity of the member centers and OPCA. So this is all about really Gil's point. Be careful what you ask for. Now you have the data. What do you do with it? How do we translate this into action? And this is at multiple levels, I think. In the conversations that have come to pass over the last 10 weeks, there have been some fundamental questions about what should I be budgeting moving forward as a health center executive director in terms of internal staff needs for both infrastructure maintenance and analytical capabilities. So I think that there's an opportunity to do some benchmarking just across the membership of how are people budgeting, what kind of infrastructure staff do people have, and how can you learn from that? You have a tremendous amount of talent within your member centers. Jeremy's developed data warehouses nationally. From a technology perspective, really understands what it takes and has a lot of wisdom in that area. Carlos's group has been managing at risk for 20 years. So you have a lot of that expertise, but it's siloed, and it's not necessarily leveraged across all of the members. So I think there's an opportunity for you to do something systematic, one, in terms of benchmarking and sharing, two, benchmarking nationally. So there are other states where the association has entered into arrangements with data warehousing groups, and they're starting to use their data to see how are they doing that, what are they doing to support their members, how are they investing in the analytical capacity. And then three, getting to work on the so whats. Let's start taking some focused issues, very similar to what you've done with your alternative care model, and let's tackle emergency room utilization or readmission or whatever the topic is beyond what you're already doing, and see how you can start to move the dial on some of those indicators. What are the specific interventions that you could package and put into place that are moving forward? What's your role in managing the continuum as patients are coming out of the ER and going into SNFs? There's a lot of effort going on nationally in primary care's role in managing patients across that continuum. And those are the high-cost utilizers who are coming back to the ER and then up in the ICU, back and forth to these high-cost settings. Well, how can you better manage that more effectively? What interventions could you develop? So it's proposed as part of the strategy that you as an association are saying, okay, we're going to start working on that more systematically. We're going to try to pool our existing knowledge, benefit from the expertise within the system, benchmark externally, and then start to pick a couple of focused areas that represent high leverage opportunities for you to have an impact, and start to really go after some of those and build the analytic capacity, but also the capacity as organizations to develop interventions to have an impact on that. So let me stop and see what questions there are on that aspect or that concept. Yes, Gil.
Well, one of the things, as we got into analyzing who some of our most high-cost, high utilizers were, oftentimes it fall into things that wouldn't necessarily be picked up in claims. So there are socioeconomic factors, there are psychological things, there's family support issues that have a real relevance to whether or not that person is going to be making frequent trips to the ED or to be admitted, and so we found that it was almost low-tech interventions with community health workers, social workers, that could make a difference from the person with a panic attack, just calling the ambulance every time, they have an issue rather than having a direct support person. And so I think one of the opportunities we have is how we roll in some of that other kind of data that we wouldn't necessarily get from, a feed from the health plan. This is other stuff that we have to, it's kind of more around the social determinants of health and how we integrate that information for the populations that we're serving.
So Gil's bringing up a very important point that this is not limited to claims utilization administrative data, but your effort should really go beyond to see what data sets can you pull together that will enable you to develop a much broader picture of the population that you're serving. And that can include some state databases. I think Jeremy brought up in prior conversations the homeless databases. They're by region, I think you had mentioned. So you have to work with multiple regions and not a single database. That's an example of data sets that could be brought together. There's other data from the state, whether it's school system data, library, incarceration, other types of social determinant data that if you start to weave it together, you become the Amazon and Google-like capability to start to really drill down and understand your population. It amazes me that I can go on and do one search on the internet, and I'll drive by a mall. I was looking for a vest for a Christmas present, and I'm driving by a mall, and it pops up a message on my cell phone, right? This vest exists here at this mall. I think, well, this is insane. I mean, how are they tracking me like this, right? Well, we should be able to have some of that leverage with our own patients. What are we knowing in terms of their behaviors? Where are they? Where are they? If commercial groups can get expenditure data, wouldn't you like to know that these patients who are underserved, where are they using their dollars? How are they leveraging them? The Gap and several other companies came together and formed a company in Washington, D.C. called One Economy. And they found that underserved people buy clothes. Imagine that, right? Well, they said, that's an economic engine. So why not create a portal where it makes it easier for them to get access at a discounted rate, clothes from the Gap? So they created a not-for-profit, go into housing units, put computers in that provided certain social services that provide them with job training, help with a resume, getting their food stamps, getting their Medicaid benefits, so on and so on. But there's also a click on how to order off the Gap there, right? So there's a self-interest there, right? But they're using the big data to reach those populations. Other comments in terms of interaction? Yes, Jeremy.
So I have one on this. So we could build or buy a really sophisticated data warehouse, but if we don't have data-driven cultures within our organizations, it won't do us much good. And so that's something that we've really been trying to work on in Central City Concern and other data warehouses that I've been involved in. Unless we have that culture, and kind of how do you do that with people that have been doing the same type of work for 30 years to really dig into the numbers and try and create different interventions based on hospital data. So I think that's something that we can collaborate on together is kind of how do we change the culture within our organizations to really leverage and utilize these tools and think about these problems in different ways.
Right. So part of that area is really building the internal capacity, the culture change in the organization, skill building on the analytical tools beyond just understanding a run chart for PDSA cycle, but it's really understanding some of the more sophisticated analyses and how to use this data to manage a population. Someone else had a comment. Go ahead.
Go ahead.
Thanks. It's kind of short. That comment and the one that you made earlier, Gil, about the data analytics makes me think of something that I've been kind of kicking around in my head. And it's the soft skills part of this data strategy that is needed, and I think it's implied, or we might want to make it explicit, and it's like the people skills piece of it. So it's culture change, but it's also succession planning, and it's also when we talk about skill building, it's what's the right word?
Capacity building?
Yeah, I think it is really kind of capacity building for the people who are actually using this kind of work, and it changes the whole expectation. So we're kind of we're raising, we're upping our game. I don't know how else to say that piece, but it's the actual people change management. That's the term I wanted to put in there. Change management as it relates to people, culture, and the skill sets that we're going to use going into FQHCs in the future. I think is a specific strategy that we ought to make the foundation for this.
William?
My comment's similar. I think the concern I have is that we see CCOs wanting to embed staff into our organization. And I think that might be a transition strategy, but I've basically said no, because we need to build capacity within our organization to really grow and move forward. And so if someone has a best practice, I'm always glad to learn from that. But I don't want that best practice designing how we deliver services to our patient population. And so I think, that capacity building, or recognizing, at least what I see going on with us, is attaching more dollars to their strategy. And so it kind of brings us into their structure, and we become part of their system, and that's how they see us, not as an independent organization that maybe is negotiating, rates and contracts and membership. And so I think that's a risk that we have if we don't build that capacity within our own organizations.
So you have to have the sophistication to be able to offer the same capacity as others are offering to do for you as potential partners. And that requires some internal investment. And that investment can better be leveraged if you're sharing that across the environment and learning from each other. What are really the workflows that you can adapt to your environment rather than having to just rent a resource to come in? Gil, did you have a comment?
Well, I was going to say it kind of speaks to how we see ourselves. If we see ourselves as part of an integrated, even virtually integrated system, because we're for managing costs and really doing population health. It's in our interest to think of ourselves, in an integrated whole with the payer and the provider, and the other parts of the system. But we have to do that in kind of a virtual way, because corporately we're not structured that way. So how do we keep the autonomy, I think, that you're talking about, and yet for the best interest of moving the triple aim, is really thinking about it from this integration standpoint.
So you're talking about being a best-in-class partner within an integrated system, that they would rather use your care managers than the payers because your care managers have better capacity, closer to the patient, have the data, and are able to outperform in this new environment. So it's really learning how to partner in a very different ways, maintain your autonomy, but having really the best-in-class performance as this new partner. And to do that requires the data, and it requires the skill building and the capacity building internal. Any comments from the phone in terms of this need to collaborate on building capacity, understanding IT investments, analytical skills, partnering skills, data use skills, and partnering on interventions? Any comments from on the phone?
This is Dan at RCH. I do believe that is something that I'm glad we are, or folks are discussing it, but really the skill and the difference in skill sets, especially if you haven't had your IT managing in those areas, any of the data modeling, the DBA skills that for queries, and how you are going to be modeling your data for your organization. So back to the statement of one group's best practices is great for that group because that's their model, and frankly, in their design, they can afford that, and that's what they need, to operate at that level. I think some of our organizations aren't in that ballpark, and those skill sets some of them are very expensive. And how we can use those in collaboration is something that needs a lot of thought.
Yeah, very, very good point. I think especially in rural areas, it's today's Wall Street Journal, the 3 Indian Health Service facilities in North Dakota are being de-accredited from Medicare effective Saturday. They can no longer see Medicare patients. And they are in a very isolated rural area of North Dakota and can't hire and retain people in that area to even run the place. And so they're going to be put out of business or have to find another way to get their act together. So, doing that, recruiting and retaining people in very rural areas, for some of you is a huge challenge. And it begs the question, Are there potential collaboration and partnership opportunities for shared resources in a different way than you've been doing it traditionally? That may be several groups coming together and purchase a common resource, for example, to lower your cost and be able to retain them. Doing a lot more virtual, where maybe we won't have your resources on site. Maybe they're going to be in here in Portland, but they're serving you in a rural area in a different way. So all of that, I think, is part of the discussion of what is needed in terms of your capacity and what's the most cost-effective way to build that meets your needs. Any other comments on this component? So we're going to get access to as much data as we can from the different data sets and try to weave them together into a strategy. While we're working on that, we're going to be trying to build capacity to be able to use the information and get to work. So that brings us to a third element, which is the middle box, which is develop a data ecosystem. That's a little bit of gobbledygook, I guess. So let's try to make sense out of that. Well, what this means is that it's unlikely any single solution, whether it is a Cure with Ochin or a Zara with another group, any single solution is going to meet all your needs. And that many of you are going to be in environments where you are very far down the pike, have made investments. You're not going to suddenly give all of that up for other pathway. But what you can do is agree to the spirit of sharing what data you do have access to and piecing it together into a data ecosystem. There are now the technology and tools to be able to abstract data from different data warehouses at different sources into some common tools that allow you to achieve that end. And the cost of doing that is coming down increasingly as time goes on and as more tools are developed. So this means that if Carlos's group has made an investment, has their data warehouse already using Zara as a tool, and a group of you are using Ochin and others, that you're going to agree in the spirit of trying to find that one common integrator that will enable you to connect all of those data warehouses, data sets, so that you can have the tools that are needed to live out the spirit of this strategy. And this is why the data specification was developed, to try to outline what data do you want, how are you going to use it, and where possible to get to a level of detail that would point you in a direction of what we need to do. So let me just stop and see what questions you have about that concept and what the implications of that concept means. Any questions?
I think that's a real practical way of looking at it. I mean, I think it recognizes what the current environment is, and that, you know, CCOs are kind of off trying to build their own data strategies, and, you know, depending upon the market that we're in, we're probably, you know, going to be investing in that to a certain extent, and yet there's something that we can do as a whole, you know, as a group of FQHCs across the state that is different, you know, than just what's happening with a particular CCO and a particular membership, you know, so in answering, you know, some questions at a higher level, really, maybe with an audience of the state, you know, and others, and other different audiences, you know, with our local CCOs. But I think there's also things, there are opportunities apart from aggregating the data, but what are those kinds of dashboards or things that we think of, you know, and like, and it's back to the question of, so what? You know, what are you going to do with the data? So what are those things that you need to be looking at, regardless of whether your data is coming from a Cure or from, you know, the CCO, you know, what are the indicators that you're looking at? How are you going to use that for managing? You know, I think we've gotten pretty good at that with some of the clinical data. So everybody's used to looking at the run charts and, you know, things, but we don't have the same level of sophistication around cost utilization. And so we need to kind of develop that same level there, so we're getting the full picture.
So ADT alerts would be potentially in that bucket as an example. How are you getting that information? Some of you are getting that from your CCOs now that have developed certain applications. But if you're in the eastern part of the state and a patient is coming to Portland and admitted and it's not in the catchment area of the CCO, they're not getting that alert right away. If you had an integrated system, you might be able to pick that up. And the question then is, well, what do you do with that information? Now that you know they've been admitted to a hospital or they were just transferred to skilled nursing, they broke their hip and they're now in a nursing rehab facility, what do you do with that? And what's the internal workflows that initiate that call or that outreach by the community health worker or whoever to follow up to start to micromanage that patient so it doesn't become a high-cost issue and you're getting optimal care for that patient. Other comments or questions on this notion of trying to piece together a data ecosystem at the end of the day?
I guess only in that's another opportunity to enhance our relationships with the payers and the CCOs around, like, they can educate, well, I'll speak for myself, like me, on how to really better understand and use that cost data and the utilization stuff. So we have really great experience with Care Oregon in that way, although it's still like just this, we've only taken this little baby toe in the water. But I think that's just, something like they have to speak the language they have to speak, and so help us.
So I may just throw something on the table I'm sure folks are thinking about, or maybe you guys know more than me since you've been through the process over the summer, but as you do your own, whatever it is, Acure or Arcadia or Azara, whatever you're using for your data warehouse now or will be using, then what's the added cost to get an ecosystem together or an ecosystem together? And is that like bump up in cost a little bit, or is it double the cost, or is it somewhere in between? I'm sure
it was small, was what I was remembering.
So maybe it was
a couple of thousand. I mean, it wasn't like ridiculous.
Depends what you're asking us to do. But I think most people know this, and we talked about it in previous calls, but 50% or more of data warehouse efforts fail. And regardless of the tool that we use, I think the real value here is us thinking together about what questions are we trying to solve. So to your point, Gil, the total cost of care is going to help with alternative payment models. It helps us to advocate for housing. It reduces healthcare costs. But all of us talking to the state or OCHIN or our partners about this is why we need a data warehouse. And to me, there's a technology, and the technology is easy. It's the strategy and the public policy and the change of perception that is hard. And so I think that's what's excited me about the work group and the way that we're thinking about this.
And if that was Craig that was talking, I think you're spot on. I'm sorry, this is Diane. I think that the technology pieces are a lot easier. It is getting the data in, and there's the cost of the technology for sure. All of these things are all, the things that are definable are a lot easier. The things that are undefinable are the things that are more costly in the end, and more costly on time, resources. It's difficult. It's not, these things are not easy. So it sounds really good on paper, and when you read the report, and then when you start working on it, there are so many decisions that need to be made, so many discussions that need to be had with many groups and folks trying to come together to agree on how you're going to do it and design it. Those are the difficult things and the things that really are costly.
So that was
complicated.
That was Jeremy that was talking, but anytime you want to mistake what he says for what I say, I'm all in. Go ahead and do that.
I can say it's easier for some technologists.
Much easier said than done. Absolutely, the execution. So the implications of this notion that we're going to develop a data ecosystem are that for those of you that are already made investments, that recognize that as the broader strategy rolls out, that there is tacit will to begin to share and interconnect the data so that the statewide profiles, the statewide access can be produced and will be helpful. And the question is, what are the pathways that are least cost, least burden, least impact that can be followed that make that practical? So that takes us to some of the next steps, if you will. So the next bucket on the
Can I ask a question real quick?
Oh, yes.
Yeah,
Go ahead. Was there a question or comment?
Yeah, I just was wondering, when we set up this conversation today, we talked about all these challenges and that are coming down the pike, and who knows like how soon they're going to come. But I'm just wondering, as you've gone through this process, have you identified any kind of a timeline of how long things will take? When things would be able to happen?
So the question is, as I hear it, as we're thinking about these strategies, how fast will they be rolled out? What's the timeline we can expect over the next foreseeable planning horizon? And I think there's some partial answers that we're going to come back to that here in a few minutes. Of if this is the strategy, then let's talk about what a timeline is and how it could be executed. So if I could park that for just a few minutes, would that be acceptable?
Yeah, that's just fine.
Super. So we'll come back to that shortly. Any other comments from the phone in terms of the data ecosystem?
Yeah, this is Carlos. I find the conversation absolutely fascinating. We've gone from just trying to get data to our clinics to now integrating the whole state. And it seems to me, as you heard Diane say, and we have experienced this painfully in my own system, where we can make decisions about workflows and changes that need to happen, they don't come easy. And although if we're talking about 5 to 10 years from today, maybe that's something we ought to think about and put it in some parking lot. But I'm more worried about just today. I'm more worried about the decisions that this group is about to make and to present to the board coming up, and what are the alternatives that health centers have, either individually or collectively. And I hope we can focus on that.
Yes, I think we could come back to that very issue as we talk through the recommendations here. Any other comments in terms of that beginning to think of it in principle of a data sharing ecosystem that enables you to have access to the data from various data sources? Any other comments on that for now? Okay, so the next piece was what are the alternatives that could be pursued to execute on that strategy to build that data ecosystems? And one of the questions on the table was the relationship with OCHIN and the Accuray product. In the original assignment coming in, there was a lot of questions about where OCHIN was with its development timeline. Is there capacity to execute? What are some of the challenges that have been in place with the current development? And is that a viable pathway, especially in light of the fact that they were awarded the Health Center Control Network grant to build a data warehouse and now interconnect all of you, and that most of you have signed on at the initial support of that general concept. So we spent a fair amount of time as part of this exercise trying to drill in to better understand where things were, what the issues are. Could a system of accountability be developed that would be able to follow through and give you a sense of comfort as a collective group on the execution strategies and the ability for the Accuray data warehouse to be able to function as this potential aggregator. So the outcome of that process were a couple of things. Some due diligence was conducted. I spent a fair amount of time both telephonically and on-site with OCHIN, kind of probing and better understanding the capacity, the systems, the issues, the overall ability of the organization to really proceed on the vision. We developed a series of questions as a work group that provided to them, developed the specifications, provided to them, and then had a presentation where they went through their journey and tried to address the questions as best on current knowledge. The output of that was that 80 to 90% of the specifications appeared to be in the base design of the Cure product or in the current development plan. There were a couple of items that were not on the plan, but were options for future development. So in terms of the general spirit of design of the data warehouse, it seemed to be factored in. That said, it is still a relatively nascent data warehouse. It is not fully developed. The reporting tools are certainly not fully developed, and there is an opportunity to shape that development through the accountability structure that was proposed. The accountability system resulted in a few clarifications in terms of who at the end of the day is personally accountable for various aspects of delivery and execution. So they went through identifying the key decision points on that. What vehicles are there for input and being able to shape the development pipeline and priorities. So a new work group was proposed as part of the Cure rollout that would be specifically focused on Oregon health centers, both OCHIN and non-OCHIN members. Are there going to be costs associated with supporting this health center control network data warehouse? And the answer was no. From a licensing perspective, that whether you're an OCHIN or non-OCHIN member, that was all built into the core grant. However, if you're a non-OCHIN member, there could be costs associated with interfacing the data, whether it's a direct interface where you have to develop those interface links, or it could be done through some data abstraction, which would be probably lower cost, but more in a batch mode and less real time in its execution. But that could be a potential pathway. Now, the proof is in the pudding, long term. We discovered that OCHIN had invested in a very robust, expensive product known as a Caradigm platform. Before that, it was the Amalga platform supported by Microsoft. It has a long history in the market, but as OCHIN learned, as several other groups around the country, Hawaii learned this as part of the Beacon community and others, it was very difficult to scale up and to manage cost effectively. And in the end of the day was so cumbersome as a platform that decision point was made to move off of that over the course of this past year. Although the Cure name has been in the market for 3 to 5 years and have been operating formally as that Caradigm platform, they switched this past year. About 120 days or so ago, started and rewrote the platform, which was a very aggressive project, I must admit. But given that, they put the investment in and also realized that they were hitting a wall in terms of some of their internal capacity and challenges. So they had to stop selling their platform to the external world around the country. They have grown significantly, as all of you know, beyond the Oregon borders, and are now serving multiple states, I think 400 centers across the country plus. So they've stopped that. They've added some additional staff, and they've redirected resources to try to finish the development and implementation of the Cure platform. They are chomping on the bit. They have reached out to me and said, where are things with this process? Because we would like to get that work group really functioning and helping to advise on the tools and the use of the data, what reports that I think Jeremy and Gil were speaking to before. So that's one action item that can begin sooner than later that we'll talk about in a few minutes. They already have interfaced with all the CCOs because their members are using their platform as a hosting facility, so they've had to interface with most of the CCOs to provide the claims data, the encounter data already from the EMR. Most of those interfaces are one-way. Most of the CCOs have not fed back the data in terms of their full claims data set, but that could be easily developed, so those pathways are there. And they already have the state data in, again, the research side. So they have mapped through to the state the ability to get the data, which is sometimes a stumbling block architecturally that just creates some time for ramp up. So if you looked at the fact that they have a federal grant to support all of you, they already are interfaced with the state, they're already interfaced with CCOs, if the Accuray product can be really refined and developed and the accountability system works in execution, then that appears to be the least cost, fastest pathway, least disruptive to meet all your needs. And that would obviate the need to go and interface with every other CCO to get the claims data. If you could get it directly from the state, it wouldn't be a burden on all of you. It'd be a very least cost option that certainly seems to make sense to want to try to test that out and take it as far as you can before you switch horses if that decision is made. I'll talk about that pathway as one of the last items here in the strategy. So let's just stop and talk. One just point of clarification that I want to get across that is very, very challenging with data management, and this is there's two components. One is attribution, and the second is data integrity. The attribution is always a challenge. All of you are dealing with that now, where you are being told you're being held accountable for members you've never seen. They've been assigned by a payer or CCO, and the first you've heard of it is when you get a report saying this is your patient, and their numbers are outliers. So that reconciliation process is very, very, very challenging. I did a pilot in West Virginia with 3 payers, a group of health centers and private practices. We started with 26,000 patients, and at the end of 18 months, they could only attribute 3,000 in a pay-for-performance demonstration. And so the records of what the health centers had and what the payers had and who was assigned to what just didn't match, and was a nightmare in terms of calculating the pay-for-performance. People came off the rolls, all of the issues that go along with that. So that's always a challenge, any environment, and part of the puzzle we work it through. The second piece is data validity, and being able to see what your EMR says according to the data and what the report from the data warehouse. And lots of issues go into that. Some of them can be coding issues and how it was set up, that there were just errors, and so those have to be worked through. Some of those are interpretation of the measures and how they were set up. I think in the report I gave an example of mammography, that if you wanted to look at you were in a pay-for-performance program on your mammography rates, and you wanted to see how you're doing, and if you ran a report and say, okay, let me see, the guidelines say that women 50 years and older should have a mammogram every 2 years or so. Let me do a report on any women over 50, and I pull up and look at that report, and then I look at the data warehouse, and the numbers don't match. They're off by 100 patients. And you start, immediately, what the heck's going on here, right? And so you end up, there's a concept about a single source of truth and multiple sources of truth. So one of the challenges is that all of you have to really perfect your internal data systems to where you're extremely comfortable and confident on your single source of truth as your home data set. And that means the right coding, the right data integrity, the right cleanup, the right systems, that culture of data management internally. And that being very comfortable, that's your single source of truth. Okay? But you also have to be comfortable in multiple sources of truth. So in that case of a data run, the data warehouse may be using the NQF definition, which the payer is using for HEDIS. And that definition says that the guidelines say every 2 years you need a mammogram. So a woman over 50 hasn't had a chance to have those 2 years, so that they're going to pull every woman over 52 and over who has not had a mammogram. So you're going to get a different number in the report from that. And so you have to really get down to the detail of what are the numerators and denominators and definitions and how are the data pulled to understand that. But we can spend 2 years on the data reconciliation and miss the forest for the trees. If your rate's 34% and the average in the market's 60%, you're off by 100 patients. Okay, what are you doing about those other 40% of the patients that are not getting their mammograms. We have to be willing to accept that there is a certain amount of inconsistency in the data, and that there's a margin of error, whether it's 5, 10%, 2%, whatever it is. But if the gap is so significant, what are we doing to bridge the gap while we're working on the data cleanup? And all too often, we make this a serial issue. Let's get the data right before we act, because we want to be perfect, we want to get it out, and we miss the boat. So it means you're leaving money on the table, potentially, for things that you could be collecting, any mammograms that you bill for, any venipunctures or diabetes or whatever the indicator is, colorectal kits, all of that you might be billing for. You may be leaving money on the table for the patients that you're not collecting while you're working on the serial cleanup of the data. So the message is that there's always going to be some messiness with the data. Doesn't mean you don't try to perfect it and work it through, and usually it takes some period of time in a transition of a product, but once you get through that, it's an ongoing maintenance issue of constant reconciliation, which means you have to budget internally for those resources to think about the data cleanup. So that being said, let's just stop and talk about the OCHIN piece, because I know that was a concern coming in. Most of you that participate in the work group, you could speak about insights or lessons learned. But one of the proposals is to see that as far as it can go, implement the accountability system that was developed, and see how it plays out. And I'll talk about a parallel strategy at the same time. So let me stop there and see your thoughts or questions, comments, observations.
So this is Carlos, and I just wanted to, as a non-OCHIN user, I want to understand what I'm hearing, because I think that it is imperative for us to have a clear path to decision making. And I concur, and I am on board with the need that we have to integrate our data to move through as a unit in order to be able to do the things we need to do around PPS and around value-based and around risk contracting. So I am on board with all of that. But what I'm in the recommendation is we have a system that has been funded by the federal government to some degree. However, we don't have yet a complete data warehouse. We have a system that has gone independently from any other sort of larger, more structured system. We have a history of long-time development, and we are not sure how this system is going to perform within the next, as you said it, a very aggressive pathway into development. Nothing to say about the requirements the health centers will have to meet around validation, et cetera, of all the things you talked to. So I'm trying to understand, why would a system like ours or any other who is not a part of the OCHIN system today not want to jump in? I understand those who are in OCHIN and want to keep going. Okay, I get that too as well. But I am troubled that if half of the system goes one way and half of the system doesn't, or more important, if most of the people go this way and the system doesn't develop in as fast and as clearly as it ought to be developed, all of us end up paying the consequences of that. Because if the majority can't prove value-based or risk contracting capacity or analytics capacity, the rest of us are going to suffer through that process and not understanding how we're going to meet the demands in the future. So I just sure that people are aware that we are taking a huge gamble. Even if I don't participate, I'm taking a huge gamble on a system to be able to perform over time. And it is that what we're going to put our money on, meaning our reputation, our ability to do the things we need to do. Is that what I'm hearing on the recommendation?
Yes, in part. Let me try to clarify, I guess, a piece of that. So yes, what is being proposed is for the near term, you continue down the pathway of trying to execute the vision of the Health Center Controlled Network Grant, which was to develop the data warehouse, getting the data from the state or from the CCOs and other data sets that would be able to offer all of you a tool, whether you're an OCHIN or non-OCHIN member, be able to have the tools to be able to manage the population more effectively and to be able to have the data to advocate as you see fit. Now, there remain question marks on the execution and the reliability, which I think have to play out, which is why the accountability system was proposed. But given the investments, that is one of the recommendations, as if they can get the total cost of care data and other data sets directly without you all having to interconnect and do everything, then it's a faster pathway and low cost option that gives you additional tools, Carlos, to your organization without having to go ahead and interface everything directly, because it's coming from a central source. That's the punchline.
And Carlos, this is Vanetta. So you know the perspective I have. But I've not been at all of these meetings, but I didn't hear anything in any of the things that we looked at that were 100% guaranteed when it comes to this. And where I'm sitting, I'm not sure that this OCHIN option is any worse than any other, because there are no guarantees around this, because it's so nascent in some of these things. So I'm not understanding the other part of what's under what you said, because I didn't hear any guarantees with any organization.
So I think we're in the same boat as Carlos, as we're not OCHIN members, right? And we've invested an awful lot in our data warehouse, and we're really proud of it, and it's really helping change our business models and the way that we're thinking about helping homeless folks. But we're a little bit of wait and see if OCHIN can deliver, right? So we have our data warehouse, and there's a lot of value in it, and we're continuing to invest in it and work on data integrity. We know that if we can get the total cost of care, it'll really help us, and if they can deliver on that, that's great. But we're doing both, right? And there's going to be some investment to get onto the OCHIN system, and we'll have to reconcile their data with ours so that we have a single source of truth, and that worries me a lot, right? If we're getting different sets out of a Cure as to our data warehouse, what do we trust?
And then the state, right?
Yeah.
Right.
But I'm with you. I don't know. I mean, we could spend millions and millions of dollars with another vendor to build this for us, and part of it is there's the actual technology that I spoke about earlier, but it's us collectively driving OCHIN to ask for what we need to ask. And even if they fail to deliver on it, if we have the political will to get the total cost of care from the state, then we've won, right? Even if they kind of fall down, and there's some risk in there, Carlos, as you say, as it takes us 3 years to get there, then we have to start all over and build in that thing. But I don't really see another option either.
I'd like to say something. We've not been shy at our health center talking to OCHIN about our dissatisfaction with the customer service, because it's been deplorable. Last year at UDS time, we had to repeatedly fight to prove that our data needed some changes and the reports needed changing. This year, they have really focused on the customer service. I mean, I think they heard us because, like I said, we were quite vocal with them, and they themselves had learned of some situations that they thought they were embarrassed by the communication. So when I read that they're really focusing more on a Cure, because I know they've asked, why do you not use a Cure? It's because it's not helpful to us. The data's wrong. You're using NQF. It's not helpful for what we need in order to be a health center. I think they did lose track that their base was health centers and that they were focusing on all these other things. So when I read that they've understood that and they're cutting back on going into new markets and doing that, they really want to focus on this, I'm feeling more optimistic, because I think that they did hear us and say, when we submit a JERO, we've already looked at that data, almost every possible way you can look at it, and we know there's an error in the report. So why do you keep making us prove over and over that we're right, and you have your right button on, and you don't listen to what we're saying? And we've had the vice president come and talk to us, and I think they really have heard us. So I'm feeling more optimistic about this, and in terms of a Cure, that maybe they really will listen to our needs and modify it. as we need moving forward.
So with that, there's one last piece, which is the last bucket is don't put all your eggs in one basket.
Right.
This everything's proceeding, trying to be very strategic and mindful of your resources and timeline, and so it makes sense to follow the OCHIN Accuray pathway as far as you can take it. But in the meantime, what's suggested is that you begin the process now of more systematically looking at alternatives to have a plan B in the event that you have to switch. Now, keep in mind that even if you decided you did not want to use Accuray, OCHIN could host another platform. They could host Azara or I2I or Sisense or any other platforms as a hosting facility to integrate your data. If they could get it from the state, and so let's say they get the total cost of care data, but you don't have confidence in Accuray, it's not working, they're not meeting the timelines, whatever, you could all decide, okay, that's just not going to be viable, we want to switch to another product. So your decision point then is it hosted within OCHIN, working with that other third-party vendor, and get that up and running, or do you have another pathway of how that's going to be hosted, either by the vendor, could be a cloud solution, could be lots of different ways to host it. So that's a future pathway, but don't make that mutually exclusive that all the basket have to be on Accuray. That is a future potential alternative. There would be cost associated with it because the expenditures on the health center grant have gone into the development of Accuray, so there's not going to be much left to switch to another vendor, so that means poning up for another solution, but again, that may be a pathway that you decide. At minimum, being aware of how other vendors treat the data, present the data, visualize the data, the types of reports is very educational and makes you informed purchasers. And so I think that alone is a very helpful exercise. And I recommend you look at some extremes. I think you should look at one end of the spectrum, the SAP Epic data warehousing tools that have been developed by this consortium of 40 centers around the country. It's state-of-the-art, all the way down to getting data on handheld mobile devices for your leadership team to be able to see and use them in huddles in the morning with point-of-service data for your population. It's worth seeing the architecture, the tools, how they're using them, how they're driving cost. And they have very demonstrable results of how they're driving cost out of the system using their big data down to point of service.
I'm curious, did you ask OCHIN about why they didn't choose that solution?
Well, it's very expensive.
Yeah.
It's you're talking big dollars, okay? But worth saying and being educated on that. So that's one end of the spectrum. And then there are the tools that many health centers are using, the Azara tools, the I2I, that are more smaller, lower cost data integrator tools. So it's worth seeing all of that and understanding what the cost implication is. What would it mean to do, what are the transition costs for that? What would be the real requirements at a health center? How much would you have to increase your bandwidth to be able to support that kind of application? What kind of internal staff would you need at the local site to be able to support all of that? So educate yourself on that and be prepared that if you need to make a future decision point while you're working through that total cost access piece, that if you are not comfortable, then you make a mature, collected decision after trying to take it as far as you can and say, let's take another path now, and let's find that solution. So, Carlos, does that get a long-winded answer to your question that you raised a couple of minutes ago? Does that help clarify what we're talking about here?
Yeah, it does. I mean, I think that's a prudent thing to do. I'm just a little sort of stunned by the notion that we're going to look at other alternatives just in case this doesn't work. And it seems to me is how do we know what it is that we're looking if we haven't looked at other things? So I wouldn't do it that way, but, hey, I understand the direction. If that's all what you want to do, then that's what you should do. I do think that there has to be some ability of those who have not seen other things other than the system that they're currently using, see how other systems function what do they have, what are their costs. All of those are outlined, and we have advantages today. 3 of the CCOs, for example, in the state of Oregon have chosen Arcadia. Maybe they know something we don't know, and we ought to look at what they have done and understand what is it that they're getting out of this and how is their systems working before we jump in to do other things. So I'm just saying everything you guys make, I'm good with it. I'm not going to switch. I'm going to move on with the things that I'm doing, and I think that be happy to help in any way I can, but I'm not going to put my entire system on the line for something that hopefully will be developed in the future.
Carlos, this is Craig, and I thought what I'm hearing from Roger's recommendations, or the group's recommendations that they've gotten to, is that we do parallel both, right? That we go forward and see if a QRA can work, but also look at other solutions, see what they have, see what they cost, and not wait for the end point. Because I think what you say is probably a concern that everybody has. If we're 3 years out and we're no farther than we are today, we haven't done this right. So I think that's why the parallel processes go into effect. And so, if we're looking at, quality and cost, I want to go back to quality. Some health centers are either not on a QRA or not in OCHIN, and so they're developing their own. Right. Some that aren't on OCHIN are still developed. They're using I2I or something else, some kind of platform to check their quality metrics against a QRA's, which is why they know that there's a difference. So I think there's still some of those multi-part strategies going on that are more costly than having one until we get the single source of truth or multiple sources of truth. So I don't think people are sitting on their hands unless I'm totally missing something because I'm not in the health centers. So, but the total cost of care we don't have yet. So how do we learn from the quality piece and translate that across to a strategy on total cost of care so that we're paralleling and not falling behind 3 years? I think this what's happening here with Roger helping us. I think he's done a great job is to try to make sure that we learn and fast track so we're not at point A where we are now 3 years from now.
I agree. I think part of what I'm hearing in sort of some of the concerns expressed does get back to that timeline question. I don't think that the recommendation is to wait 3 years until making that kind of decision about potentially going elsewhere. I think that may be part of where there's, if not a disconnect, a concern sort of expressed among folks, like how long do we follow that path of continued investment? Because the time in the accountability process, that is an investment, even though the HCCN grant supports OCHIN and QRA, but sort of when and where is that decision point about moving elsewhere versus continued effort into that? And I think I'm hearing that it's not that we're wanting to do that fairly swiftly, but
so
that's
Roger,
really the conversation here.
For those of you on the phone, this is Ron, and I am one of those non-OCHIN plans, and so I am looking at to some degree duplicative expense because we're building our own data warehouse and would have some admitted duplication to make interfaces into whatever other database this would be. So part of my decision making is how long do the wait and see before I jump in. So to that question, regardless of for all of us, Roger, would you have recommendations on both the timeline and the markers by which one would say we expect this performance indicator by some period of time, and that would help everyone understand at what point do we jump to Plan B, because there is a little bit of the frog in the water a situation. It is very hard to make a jump once you're going down a path, and then all of a sudden you realize, oh, we should have made a decision a year ago, but we didn't see it at the time because we thought, 2 more months and we'll have progress. And we've all done that in any variety of decisions.
So let's talk about a timeline and getting back to the question that was posed earlier about timeline and in the context of this discussion of what would be practical and reasonable. So here we are, Thanksgiving, middle of late November, with the rest of the year going pretty quickly. If you were to adopt the recommendations that I'm going to present to you in summary here in a couple of minutes, what would propose is that you not wait at all, but you begin right away of teeing up a series of vendor presentations that could all take place over the next 8 weeks, 6 to 8 weeks. You can run them every 2 weeks, different vendor. I would not go through the whole laundry list. I'd be very strategic. I think you're probably talking about 5, perhaps, that really give you a sense of capacity. And in that, I think there's some opportunities to pursue leverage. If 3 of the CCOs or 4 are getting the Arcadia system, is there a potential to get a group discount in some way? Is there a potential to encourage all the CCOs to come together and purchase that on your behalf as a collective data warehouse tool? I mean, those are all part of a strategic discussion that could be pursued and look forward. So I think you'd be in a position, by end of January, early February, to know what's out there and the cost to see what alternative pathway is there. I would suggest to you that you would want to implement the work group that would be overseeing the accountability system and designing the tools for OCHIN, working with the Accuray system. You want to operate that right away, get it going right away. And I would suggest to you by probably the end of January, you would be in a position of having a sense of confidence or leery on what the execution strategy is. If you have a good feel by the end of January that a reasonable spec has been outlined of what you want in terms of your tools, of how it's going to function. Now, admittedly, it's a little bit of a challenge not having the source data from them if you don't have the total cost of care data. But they may be able to do a test pilot internally on the data set that they're getting from the state to see how it would work, and from data visualization tools, for example, just set up a sandbox using the state claims data and their version of an instance of Accuray to see how it would work.
So a question for you: so if we take a look at these vendors, right, it's hard to talk to the vendors unless we know what to ask them or what our requirements or what we're building. And so, is there an example that you know of a data warehouse that was built with all state claims in the nation?
With all state claims, well, there's a mixture. Missouri is an example. West Virginia is another example where they are getting some claims data from the state. It's not necessarily a total package, but to varying degrees. So those are 2 examples. Massachusetts is another one where they have an all-payer data warehouse that they're interfacing with. Maine uses the University of New Hampshire, is getting claims data from the state, and the University of New Hampshire is maintaining a data warehouse for them. So I think part of your benchmarking, and I think Craig has done this a little bit already, and as part of your discussion with some of the other PCAs, how are they managing their data? I don't know if you have any other insights, but I think
we brought in a few PCAs to talk to the group, and so we brought in Idaho, New York,
Missouri,
yeah.
And both New York and Missouri through Azara are working on it. They're at different places with respect to that total cost integration. And I wonder if we may need to go outside of health center specific examples to really get a sense of where that's working well. Is kind of my sense. I think we may need to broaden that net because
South Carolina has integrated at the state level all their state databases into a single data warehouse. So and it's connected to some of the Medicaid claims data. So now you can see if a beneficiary has a driver's license, library card, have they had any speeding tickets, have they, you can see a complete profile of the beneficiary and start to look at correlations of the data.
Now you know what I bought at the gas.
Hopefully not a complete profile.
Yeah, the challenge is the database is grossly underutilized because nobody's developed the capacity to be able to start to drill down and effectively use the data. And the state hasn't had the bandwidth, but it's there. So, getting back to the timeline, your work group could develop, in terms of the vendors, I think it would be very easy to put together a RFI packet, if you will, that outlines the number of sites, potential users in the state, number of beneficiaries, projected claims volume that you would anticipate that would be able to give a vendor enough information to do an informed presentation to you and say, this is how we would work. This is how our general approach to integrating the data. We're a data abstractor, not really a data warehouse, or we have a data warehouse and an abstraction tool, and we're using Tableau as the visualization tool, or we have developed our own visualization tools and so on. So I think you could have some informed briefing piece for the vendor that they would do a presentation. As part of that, you want to know ballpark pricing. Is it put you out of the game, or is it something that's very competitive? This on a per health center basis, this is only going to be $5,000, or is this $100,000 per health center? Those are different magnitudes that you'd want to know. Some of them are total cloud applications. The SAP one uses HANA and a cloud-based environment, and so it's all no local infrastructure other than pretty simple reporting tools. In other cases, they're distributed architecture, and you're hosting it on site, and whether it's at OCHIN or a third party. So all of that, and using your specification that's already been developed. This is how we wanted to use the data. That would be presented to the vendor, and you'd be asking them to come in and show different levels. Show us what we could do in a huddle. Show what we could do in a population level. Show us how this would flow. So those could be tightly scripted to give you enough information. Again, could be accomplished, I think, by end of January, early February, where you'd have enough information, I think, to be able to make some decision points. The OCHIN piece, again, I think you'd have to have your data work group that is functioning. On the slide here, in the strategic plan that's proposed, it's suggested that you formalize the work of this subgroup that has been acting over the last 12 weeks and create a formal committee of the OPCA. That would be a data governance committee. It would have responsibilities beyond just the OCHIN activities that we've been talking about and the exploration of vendors. I think there's some other data policy issues that you probably should be talking about as a group of what are your comfort level with transparency and sharing of data. What is your comfort level in terms of who has access to the data? If you're going to set all of this up, what are going to be the rules of the game in terms of who gets to use it? Can any of you resell the data? For example, I've mentioned this before in some of the calls, the pharmaceutical companies are offering big data. One hospital system, $10 million to have access to their EMR claims data. They want to see what the impact of all of these drugs they've been ordering, are they really having an effect intended? Or are they about to get exposed in the environment for the data not supporting the reality of all the marketing? So, how are you going to handle that? If you aggregate all this data, it's very, very valuable. Vendors, others would love to get access to it. The medical device companies, I mean, everybody that might be uncle potentially coming after you to get access to the data. So there's some ethical policy decisions I think you have to think through, and so that's some work of a data governance committee. What's proposed is out of that data governance committee, you have a subgroup that is really working with OCHIN and overseeing this accountability system and developing the specification for both OCHIN and non-OCHIN members of how is this going to function? What do the tools really look like? And this is the specification. How are we going to get it, assuming the data is available to be able to populate? And that's where you will have your comfort level. So my suggestion to you is that by the end of the first quarter, I think you should be in a position to have a feel whether the Cure pathway is viable or not. And at that point, you're pulling a trigger, having done your homework to see what the alternative is, and being clear on what the cost of those alternatives. And again, you may not be 100% on board with that strategy. There may be a subset of you say, you know what, we're willing to fund a different application, and I'm going to put a halt on my particular data warehouse, and let's go together, 6, 7, 8, 10 of us, and we're going to do this as a group, and we'll do it through OCHIN or other group, however you want to do it. But at the end of the day, coming back to the design principle, you want to interconnect all of this so that OPCA has the data it needs for advocacy purposes, and you have access to the data you need through this federation of integrated architectures that can get you the tools. So let's stop and talk about that timeline before we come back to the recommendations as a summary. How does that need a sniff test? And Carlos, does that partially address some of your concerns about timeline?
That's really quick. Is it possible, or would you? It would be great if it was possible. We could get to that clarity by the end of January. But do you see that as part of the decision, just practically at the end of January, maybe here's where we're comfortable, here's where we're not. We need some more information, and then going to probably Carlos's concern or others, and then we need to cap that. I mean, there can only be so many times that we go back and want more information. But
yeah, I think getting through the vendor piece is pretty straightforward.
Yeah.
And getting pricing and modeling and comfort and understanding what's available. So I think that's very doable by the end of January, early February. It depends how much time you want to put into it and how you organize that. But you can park your decision. If you know that there is a viable alternative pathway and it's going to cost X dollars, and you do or do not have the appetite, you can park that decision, and then depending on where you are with the journey with OCHIN and Acure, you could put that off for future. You may say, you know what, we've got an alternative, but this is still worth continuing, and we're making really good progress. So let's not pull a trigger. Let's see how this goes. It's going to take another quarter to see it through, but I think we may get the Holy Grail. It looks like the state's going to release the data, and boom, we're going to have enough to start with, but let's hold before making any decisions, spending more money. And this is going to meet the needs of the group. Or you may say, you know what, this is just it's not progressing fast enough, and we need to move faster, and the price point is acceptable to the group. So let's pull a different trigger and move on. And that's just a timing issue. It's hard to forecast that, but at least gives you an option and information to be able to leverage in both pathways. I would strongly suggest that you look to see how you can influence the CCOs who are all making their own investment decisions. Is there any way to create synergy across CCOs where they can create a Switzerland as a neutral resource center? It's almost like an all-payer claims database, but an all-CCO database where they're not just each replicating and creating a burden for all of you on a different platform. Let's try to go to a single platform if possible over time. And that may take some transition based on current commitments that people have made, but if the end goal would be to optimize that resource, that's a political strategy too that I think should be pursued to see what you could do.
That was going to be my question. If this is an opportunity to leverage the CCOs, that it is crazy making, although they are doing a lot of really good stuff, but on a it's not too mini of a project, but how they did, so the collective medical technologies who created the pre-manage and the EDI stuff, CCOs all bought into that and pushed it out to us, and that was the only investment on our part is dealing with the patient roster sort of upload piece, but that was, they had everything to gain from making that work and making sure we had access to it. So it does seem like fitting the CCOs in somehow.
I think given all of your membership in CCOs at a governance level, for most of you, I think that's a leverage point. You say, let's see if we can do something really strategic here to minimize the reporting burden and infrastructure burden and the cost savings to the system as a whole, if it can be done. Again, much easier said in practice than execution. It's going to be very tough, but I think it's worth a try to see what can be done.
So, I am a little concerned about this parallel track, that it may, if what message we're sending to OCHIN and how quickly we move to develop a Cure so it's successful, if we're at the same time, evaluating, other systems and things, does that have the potential to sabotage, the strategy of moving forward with developing something along the lines of a health center controlled network? So I want to make sure that, if we're going to try to move forward with OCHIN, a Cure strategy, that we're all in to try and do that. I understand, wanting to evaluate performance and see, that it's delivering what we want, but we want to make sure that we're going in for success and not, looking, at hedging so much that, we derail the process, that we undertake.
I think it's very important to be transparent, ethical, and not play any games. And be very straightforward in the communication and dialogue. I have been, in my discussions, I have told OCHIN my recommendations and said, this is the pathway, and that's, where the discussion came up, that, if we need to switch from a Cure to another platform in the future, that's a pathway. If we can't execute on this, and, the members are willing to support another pathway, that's a viable option. So, I think as long as you're not playing games and you're doing this in good faith, I think it would be smart, given your history, your investments, and the leverage of the federal dollars, why not try to really execute on that and do that in good faith? That just seems smart. There's the potential for other federal dollars downstream. So I would see that as far as I can. If I were in your position or in a governance level, I would really want to see that pathway succeed. Otherwise, it's kind of a blemish on all of you, because you were founders of OCHIN. You were supported the Health Center Control Grant. So, see that through as far as you can. That does not negate being smart and having a plan B and educating yourselves and knowing what the cost of transition is to all the members. And so if you do it in that spirit, I don't think you will sabotage yourself. Just be very straightforward about it, and also really be serious about the accountability system. I think, as you said, you were not shy, and you've voiced your concerns. They listened, and they seem to be addressing in good faith and wanting to really see this through. So I would, be in good faith in return. From a external, unbiased, I don't think I'm biased, but from someone outside of the state, someone outside of the state, I think that there's a high potential of probability of success. I think there's a track record there. I could tell you from ONC's perspective, OCHIN was one of the shining stars in the execution of their Regional Extension Center grant. From HRSA's perspective, they look at OCHIN as a success story. So there's external perceptions, at least. Now, being in the kitchen and making the sausage is different, which some of you are making sausage right now, and it's getting burned on the edges for some of it, but that's part of it. But again, having that other plan B, I think, is an important pathway. So questions on that timeline or other comments along those lines?
I have a comment about, as we go in, we should understand what our exit strategy would be with OCHIN. And that would imply some measurable outcomes or deliverables that we would want to look at. And I think that transparency would help OCHIN to know what the expectations are, and then that they're either meeting them or not meeting them along the way. But I think if we don't have an exit strategy that has been communicated and that we have agreed to as we enter into this, I think we're setting ourselves up for failure, the failure to be able to leave if we're not happy, because we don't know what Plan B would look like. So I think that's one thing. The second thing is I look at the governance. I'm wondering who would make that decision about leaving in this governance structure here. And I wonder about conflicts of interest. I wonder about relationships, long-standing relationships. And so, from my perspective, I would look at that data committee as being the deciding body to make that decision, to exit. Now, that's how I'm looking at it.
The governance.
The data governance.
Okay,
Yeah. Excuse me, the data governance. That would be the body. And so I just would, for clarity, just to, so that transparency is really straightforward on the timeline, that we're expecting OCHIN to deliver, and if they don't deliver along the pathway, I don't think it's one decision. I think it's a multiple of decisions potentially about whether or not we should or would want to continue with them.
William, everything you said makes really good sense to me. This is Vanetta. The add-on I would have is for this data governance committee, if that's an agreement from the full board, that would be their powers or their authority to make that decision, that we really spell out at least a high-level charter for that group and what their authority is, so that it's clear on who's on there or not.
Yeah.
And I think the conflict of interest piece, we should always do that as board members, whether it's this or anything else, and we declare those things early and often, and to be really clear for ourselves. So I think that's particularly important today, but I also think that as board members and as leaders, we've got to do that all the time.
So any questions? There's a slide up on the proposed governance structure, accountability structure for how this would operate. So the recommendation is that a new committee be established as part of OPCA. That would be this data governance committee. It would have that oversight role. It would have that decision point role, perhaps in terms of future relationships with whatever vendor pathway that would be pursued. I don't fully appreciate your total governance structure, so would that committee be recommending to the board of a whole, or would it be totally empowered unto itself? I think that's part of what you have to discuss at a board level. But that entity would be the group. Underneath that would be a data governance work group that is probably with more IT operations staff that would be serving as the same OPCA data work group for Accurate. And that's the new work group that they would be establishing. We're proposing it's one and the same. So it's not another committee you have to go to. But that subgroup would be overseeing the accountability system. And in that was proposed a dashboard of measures so that you would be able to see problem resolution, the backlog of issues in the Accurate, timeliness, all of those kind of things. So there'd be a set of measures developed in a dashboard that would float up to the governance committee. But that work group would be using that as a tool. That work group would be prioritizing issues for the Oregon Specific Health Center Control Grant for Accurate. It would be providing the specifications for the visualization tools and how they will work so that you're customizing the reports based on what you want out of the system. So that group would be a real functioning working group working with OCHIN Accurate on a regular basis and reporting up to the data governance group. So those are two pieces that would be new as part of the process. And that would be the system. In addition to an accountability structure, are specific people named. There's also a regular meeting with leadership of OPCA and leadership of OCHIN to escalate any issues that need to be discussed. So for those things that just aren't getting resolved for whatever reason, you have a mechanism to bring it to the highest level to resolve. They're dedicating staff to Oregon-specific non-OCHIN members and OCHIN members. So they would have staff come out and work with each of the non-OCHIN members to quantify what the cost would be to integrate. So and there's a couple of pathways to do that: direct interfaces or electronic transfer interfaces. So they would quantify that. Say this is, for you to connect to the Accurate system, this is what it's going to cost if you're a non-OCHIN member. So to demystify what the interfaces would be and so forth. So part of this effort then would be the benchmarking that's recommended. So you would start to share information on your internal infrastructure of how are you supporting the management of all of this data, and what can you model for future costs as you start to work with your own boards and your own budgets for future years. So you're operating from a broader benchmarking sense. So that would be part of it. Any questions on that accountability or governance structure? All right, so then let's see if we can bring this all home. So let's summarize all of this to the final recommendations, and then step back and see if it meets a sniff test and the timeline. So the first recommendation is to formalize this OPCA data governance committee. This would be a new committee of the OPCA, would function like your other standing committees, report to the board, and that group would need to set forth its own agenda in terms of the issues it's going to tackle and oversee. You take the data warehouse specifications that were developed and you maintain them. You add on to them over time if there are other things that you learn from the vendors, for example. As you go through that process, you may get additional insights and say, it's really important to add that to the spec, so that if you ever have to go out for an RFP, you have something as a basis to be able to get bids back from. Adopt basically the strategic plan that was proposed. Now, the strategic plan is basically a framework, right? There's not a lot of meat on the bones, but you could put more meat on the bones. If you adopt that as a strategic framework, then you can start to say, okay, let's put real timelines on the vendor presentations. What can we tolerate? And what pace do you want to do that? Do you want to get all done in January, or do you want to get done in the first quarter? You have to decide your timing of how comfortable you are and what you're willing to commit to as a group with that. But if you have a basic strategic framework, then you can say, okay, let's get to work on what does OPCA need to do in terms of technical assistance or planning programs for your annual conferences and all the other things in the data area, as an example. So the suggestion is you would adopt the strategic plan and the general spirit and maintain it. The fourth thing then is developing the political strategy, getting to work right away on approaching the state, other stakeholders, the CCOs, on getting the total cost of care data and other data sets, the homeless data, other data sets that exist. Incarceration data would be likely. Pharmaceutical data, decision on being able to get access to the proprietary pharma data sets from all the commercial pharmacies, the CVS, Walgreens, and others. So you could start to see some of the drug-seeking behavior outside of your 340B and other kinds of things. So you get to work on that. You adopt the Cure system of accountability and put it to work. Finish working with them on a dashboard of those key indicators, setting the clear expectations of what you want in terms of the timelines, putting the work group in existence, seeing who would like to volunteer to be on that work group, and move forward, get that up and going as soon as possible, so that you can have the confidence that it's actually moving along. That you stick with the Health Center Control Network grant and see it as far as you can, and decide at what point is that milestone. That's probably one of the first agenda items of your data work group, is what's that timeline that you're willing to, that threshold to say this is where we need to make some key decision points. So that would be part of it. And then begin the process of the vendor reviews. Identify the short list that you are comfortable with. I can send you some recommendations of what I would do if I were in your shoes. It's pretty straightforward. I think that I would look at the SAP Epic product that has evolved. I'd look at a company called SciSense, which is a data integrator that's a pretty low-cost product that's gaining some traction in the market. I would look at the Arcadia / Azara product suite as part of that. I2I would be another one the health centers are using. And those four would be a starting point for me. And I think give you enough diversity in approaches and cost point and sophistication that, after that you can decide whether you want to continue. There are groups that have vendors in once a month to demonstrations, just to keep current on what the evolving technology is as an educational. You could decide to do that as a lunch and learn as part of your long-term capacity building. Always kind of healthy.
So,
Gil?
Roger, I think it's probably implied or assumed under number 4 that the political strategy should include OHA, but that should be very specific because they've already stated an interest in working with us on this.
So including OHA, Care Oregon, other, I would do some stakeholder mapping as part of your political strategy and say who do we really want to target. Get common messaging out to all the members. Here's the platform of the campaign that we're running to try to get this data so that if anybody's contacted, you have the same talking points on why you're doing this and that you're on board and that nobody's fumbling when they get that call from a legislator or somebody in the office at Medicaid or other piece. So yes. And so that's the series of recommendations that would be played out. Now, I think there's one last slide which starts to talk about what are the costs of the recommendations. I think this came up, okay? So we're having a new committee. That's not free. There's a resource implication for having a new committee. So what does that mean? There's certain staff that are currently supporting some of your IT efforts. They've participated in the calls. So Laura's an example. She said she reluctantly came in to this project as the least technical person, but she's did it in good faith. But that took her staff time away from other opportunities. There's an opportunity cost that goes along with it. There's new staff to run a committee and oversee all this. I'll let Laura kind of talk through the budget on that. You may have other consultants that you want to work with, local folks on some of the pieces, and operational support. If you're going to have a staffer, or you're going to be having them attend the HIMSS conference, the Health Information Management Conference, where all the vendors are there and staying abreast of all the technology and participating in their data integrity work groups and different activities. Some of you already are doing that as HIMSS, but you probably want your OPCA staff then. On the OCHA Accure side, assuming you're going to see that through, there's no licensing fees. That's built into the Health Center Network grant. But for those of you that are non-OCHA members, there could be some interface cost associated with that. And that can only be determined by having their people on site and meet with your IT staff and quantify it. And say, this is what you need 6 interfaces, and they're going to cost $3,000 each, or we could do this pretty simple mapping. We've already built interfaces to your product. This is how we're going to do it. So do you want to talk about what you've estimated in terms of OPCA cost?
Sure, I can, although I'll say that, as we were talking through this and just trying to come up with a ballpark, I think we were thinking in terms of not quite as quick of that timeline that you discussed. So we were, so I don't know how that might adjust it and maybe reprioritize the way we talked about investing resources. But can I get your...
And the timeline I laid out is very, very, very aggressive. Yeah. I'm very confident you could do the vendor piece in a short period of time. That's easy to set up. You can have enough information. That doesn't get you to a true decision point, because I think the OCHIM piece will take a little bit of time. But I think you could put a marker in the sand in the not too distant future of what that timing is, based on your comfort level as you meet with OCHIM and really get into the development timeline and the other pieces of that. And having non-OCHIN members at the table as part of that, I think, will be very healthy and give you some extra pair of eyes for those that have not been involved in the past.
Yeah. So I think what we considered was really, as I said, just the costs of in the coming year to really get that strategy off the ground. So it doesn't incorporate, of course, the long term. If we were to take a Plan B route, this is not technology costs and the cost of really doing that. But what would we need to sort of stand up that governance committee and process, and to staff that, to invest some resources in that, the data ecosystem work that you described, and starting the advocacy process around getting access to total cost of care, which, as I understood in the strategy, is again a concurrent path and independent of really this vendor question. Doing those vendor presentations, and I think also part of the recommendations, starting to work with the data that we do have in terms of, again, repurposing some of our existing quality and data staff around the data transparency work and sort of taking that kind of some steps further as soon as we get access to additional data. So I think in doing that, as Roger alluded to, we talked about sort of allocation of existing staff and then thought that it would be of value to have an additional staff member and to be able to support both that committee structure and also that vendor interaction and kind of to move that process forward. Additionally, we thought we may need additional consulting resources, and as I said, depending on where things go with sort of what timeline is sort of favored in this process, it may be that that's even a higher priority to kind of kickstart this and move it more quickly. I don't know the consulting resources. So this was the ballpark based on what we understood that those recommendations to be, again, really thinking in terms of the coming year to stand up that process. And so if we're talking about a much quicker timeline, I'm not sure how that might affect it,
And a lot of that cost is really transcending beyond just the near-term decision points. It's really functioning, building your capacity, the governance, all of the things is just the beginning. And all across the country, people are recognizing that this is the new reality of investments needed to be able to manage big data. Well, $800 million they invested last year in building their capacity to take data and push it out to their provider organizations, hospital systems, hundreds of millions of dollars they're investing in this. So everybody's in the game, and this is the new reality of being in the game. You're going to have that as part of your infrastructure. So that translates to a per member cost of about $4,000 or $3,800 or something like that.
Yeah. And again, this is really sort of that like startup getting off the ground, and I think depending on whether it's plan A or B, kind of where the longer term vision is in terms of how much sort of OPCA might ultimately support and really take the more analytic, the deeper analytic capacity and supporting health centers broadly. My sense is that probably would be additional resources, but this was really just that kind of startup period. I mean, I would assume we would need a higher level IT data systems person in the long run, and assuming the path we started down led us to deeper collaboration around that. This is really just kind of getting it off the ground and managing that decision process and establishing the governance.
So to help translate that, if 3 or 4 health centers, say the smaller ones in rural areas, said there's no way we're going to be able to contain somebody in our market to do the analytics. We just isn't the labor pool. We may not be able to keep a full-time person. That's something we'd like to share with another health center or two. You could have a couple health centers coming together with a shared resource, and that person might be housed, potentially at OPCA, but they would fund that, and that would be above this cost. That would be an example.
It does not look outrageous for what we're trying to start doing. It seems like it's a really conservative approach as far as kind of like the amount of resources and cost. And it seems like you all have been really thoughtful and careful about even the ask. So it's something that we can support.
So the comment is it does not seem to outrageous resource given the magnitude of the scope of work that's proposed and the current environment. And the comment was in support of that estimate. Other comments, questions?
I just have a question about it looks like it's an increase of $100,000 plus the use of current OPCA staff. And when you said 3,800, were you dividing that by all health centers, or
That was all, so that's a big question.
So
about,
if half participated, it might be 7,500 or something like that, just for sake of discussion. Is that what we're thinking about here?
I guess, yes. We didn't. We didn't go so far as to discuss sort of exactly how how it would be distributed.
Right.
Yeah.
Yeah.
Okay.
There was a question on the phone or comment?
Just to refresh.
Yeah, I'm sorry, I was on mute. This is Carlos. So I'm not quite understanding the proposal here. I think that if OPCA is going to be a convener and requires resources to do so, then I think that's a discussion that we should all have. If what we're doing is trying to find folks in the data structure that we want to build to be at OPCA, for the purpose of advancing the OCHIN system, that's a different issue. And so I'm not clear which one are we talking about.
So I think the proposals for the first, it's the broader data governance support that's needed, irregardless of whatever pathways, but to do the work that is needed to be done to help continue to convene and support, to build capacity, to see how to share resources where possible, is going to require the additional staff and manpower. Now, how those are executed, there's a subset of issues in there that are OCHIN or going to another platform. That's a subset, but would all be assumed as part of this broader work.
Carlos, I don't know if Vanetta just alerted me. You know, we already have through the HCCN grant an employee of OCHIN that is housed at OPCA and that helps to support that HCCN grant. That's on this list. That wasn't meant to imply that this is exclusively going down that OCHIN path, but that for sort of this transition, kind of evaluating whether we stay on the OCHIN path, that employee would be a current resource brought to bear. So I don't know if that was at all confusing or implying that, that's the plan.
I'm sorry, I'm asking the following question purely out of ignorance. So please take it in the best of intent. Does OCHIN currently fund any portion or operational pieces in OPCA?
No, there isn't. With what we got through the HCCN grant, Carlos, was access to the Cure software so that we can run data off of it. And then their person that's housed, we wanted that person housed at our shop so we could help manage that person to help out with the HCCN goals and objectives. But there's no dollars coming to us to do anything.
Does that answer your question, Carlos? There's no dollars that come from OCHIN.
Yep. Yeah, it does. I mean, I don't want to find ourselves in a position where down the road we're talking about. I heard early on somebody talking about being conflicted, and I'm not sure what that means. My hope would be is that if OPCA is playing the role of convener and data information sort of sharing and so forth, I think that's an appropriate role for OPCA. If what we are doing is intermingling the business of OCHIN with OPCA, then I wouldn't think that was an appropriate role.
And there seem to be heads nodding here, agreeing with you that this is the broader convener, governance, policy, and oversight role that is being funded.
Yeah.
Gil.
I'm just recalling our strategic planning retreat, and I think that we have total cost of care in this data strategy as one of the priorities for the strategic plan, right? So regardless of whether we're talking about OCHIN or Cure or anything, it's something that as an association has been elevated as a strategic priority. So we should figure out a way to to resource that, and whether it needs additional funds from the membership to fund that priority, or we're reallocating, staff or whatever to make that priority happen. I think it's incumbent to us to try to move forward what the strategic plan is.
Yeah, and I think what you see up there is the reason we split it into two, which is reallocating existing resources and what would be new, is that top figure of 155,000-ish, almost 155,000, is what our estimate is of repositioning what we have now. And then what do we need that we don't have now?
Which the members are already paying for.
Which our grants or whatever,
whatever.
Yeah.
So it's just the comment was made connecting this back to the current OPCA strategic plan, where this whole issue of data was brought up as a strategic priority. So efforts already have been put forth to reallocate staff to support some of the activities, and this is above and beyond now the seeing this through fruition to operationalize some of the strategic vision. Other comments or questions? Yes?
Roger, this is Blaine. So one of the things I would like to see to make a definite decision about funding something like this is really what are we hoping out of the next 3 years, maybe on an annual basis, of some tentative deliverables. I think we're talking a lot about that, but I think that would be helpful to further the conversation of a yes, no, or go forward.
I think that's an excellent recommendation. I think if the new committee moves forward, I think one of the first tasks is what's the 3 to 5 year vision of the committee? What are the timelines, the specific execution strategies you'd like to follow? That was the purpose of having a strategic plan, as kind of a framework to jumpstart that. So then it's putting the meat on the bones of, okay, what are we going to do in terms of sharing across members about infrastructure, data capacity? What are we going to do about these vendor listening sessions, and how are we going to execute that? And let's get that going. What's the timetable on being in a position of having the information we need to know from a long-term strategic perspective what an alternative pathway would be and cost associated with that? I think laying all of that out is one of the first bits of work of a new committee. You could do some of that. Staff might be able to do some of that ahead of time, but I think that's really a collaborative decision-making process that probably needs to be put forth. Other comments, questions?
So I just want to kind of re-highlight the timing issue that Laura's brought up, because this the original intent was to bring this to the January board meeting. So we're going to be executing before the January board meeting, and which means absorbing costs in some way, and we're going to have to think about that to influence the timeline one way or another. We do have a board meeting this afternoon, but I'm not sure how we get around to, presenting this at that board meeting. But that may be a decision. Now that Ron's our board chair is gone, let's make a decision for him.
Thanks, Ron.
Oh, he's back.
You're just at an agenda item.
So let me put to the collective group here, based on the information that's presented today, the work of the subgroup that's worked diligently over the last 12 to 14 weeks, is there a consensus to move forward with these recommendations to discuss either this afternoon or at the January board meeting to move forward with adopting the recommendations and starting to execute on the spirit of the overall approach? Is there a general consensus to move forward?
I just have a question I'd like to ask in relation to that. So the costs that were being displayed there, I just want to clarify, is that part of the recommendations? Is that something that's going to be decided upon by the committee, if that's going to be approved? If you could clarify that for me, I'd appreciate it.
So as I understand it, the output of today's meeting would go forward to the board as a recommendation. And in order for the board to act on that, the question will come up, well, okay, how much is this going to cost to implement? So as part of that, these costs are part of the package to say the execution of this strategy would anticipate an additional 100,000 ballpark of cost to be able to support the staffing and resources to see through what is proposed as part of this execution strategy. So it would be, they would be in tandem, if you will.
So then would that be, if that's the case, then it could be that the board would say everybody has to cough up the money for this. Is that correct?
That would be a potential implication.
I think the way these things are handled in other primary care associations, so this is, we haven't been a vendor to you guys, and this is starting to cross that bridge to a vendor. It's been more, you know, OCHIN or other vendors are the ones that are you're buying products from. This is kind of a bridge across to that, which is you're prioritizing capacity where we don't have the resources for, and investing that in a direction that you see as a high priority for members. And so that's kind of where we're at, and it's stepping across. Now, hold on 1 second. Just tap your foot and dance for a little bit.
Hold.
Yeah, we're going to try to mute.
Yeah, okay.
Just,
I think we got it.
we muted everyone on the phone, FYI.
So
You have to unmute yourself if you want to talk.
So if you guys heard that, if you want to talk, unmute yourself. So basically, what I was saying is the way those decisions are usually made in other PCAs is they may set up a different structure or a decision-making body, whether that's another governing board or it's just a group of clinics coming together and saying, if you're in on this, then you participate. And we can't. The board or OPCA can't make you spend on something. What we can do is make a recommendation, and then figure out the parameters of which, if you do choose to go in, then here's what you get access to, and if you don't, here's what you do or don't get access to. And I think that would be part of the governance decision of the committee. So it's a different way of working that we're starting to go down, I think, appropriately.
Yeah, it seems that there's a potential for all members to benefit, from this. If we think that total cost of care is important for us to understand in terms of making the value proposition for health centers, then it seems that that's a broad-based thing that touches all of the health centers, because the case we're trying to make is not just for a handful of health centers that are kind of moving forward with the data strategy. It's really gets to the root of the model of care and who we are as FQHC. So it seems like it ought to be something that is, if it back to being a strategic priority for the association, if it's a strategic, initiative, then it's something that collectively, as an association, we should fund.
Yeah, Gil, as one of those non-OCHIN plans or programs, I agree with you. I think this is a very modest investment for a payoff in expertise. That, of course, the payoff would be differential for a program that was connected into the system. But I think the expertise gain in how to deal with CCOs in the state, the expertise and gain in how to leverage best practices, how to look at total cost of care, how to think about it, how to respond to challenges, whatever they might be. I think this is a pretty modest investment. So I would defer to the bylaws to Craig as to whether we could require programs to do the incremental investment. I think the case could certainly be made in terms of strategic priorities that this is part and parcel of the benefit, one of the benefits of the association.
Look, Craig, I was gonna just kind of sitting here thinking, how would this fit for NARA, being the, I hate to use the word odd one, I like to use unique, unique player, using an EHR that only 2 other clinics in Oregon use, and they're both federal sites.
Yeah.
Being that the Indian Health Service has already mentioned to us that they're going to shelve that product in about 5 to 10 years, and they're not developing anything new for it. Being that we see a lot of patients, clients from other states, not just here in Oregon, but other states, and they get a lot of medical and mental health care from us while they're here in our state. Being that some of those folks see tribal sites, which will not give us their data, other federal sites, which will not give us their data. Some of their services are paid through tribal dollars, through self-funded insurance tribal plans, which again won't report back to us. So, kind of like you said, I think for us trying to figure out, we've been struggling with trying to figure out that total cost of care. I know in past years, just with our UDS numbers, we're kind of the odd clinic out. Hopefully maybe that's gotten closer in recent years than it used to be. I do think it's been some great work that's been done, and I think prioritizing this is a great thing. I think there's huge value in this. How does it fit with NARA, and what will we actually get out of it when, I can tell you getting that true cost of care for us will be a huge struggle compared to Central City or somebody else or you guys that use Epic that are partners with OCHIN. I mean, how is the support going to be different from clinic to clinic? And is there going to be a lot more support to try to gather our data? Then it might be easier to get something from the county or from Lieutenant Garcia or somewhere else. That's the question that we're kind of struggling with. I think the investment is not a lot of money, obviously. If anything, we might gain some knowledge, hopefully, that we could use in some other fashion with the tribes or the Indian Health Service. But that's kind of my question back. It's more the support for the clinics that are really going to struggle with this.
Well, and I think that's the decision we're putting into two kind of decision points. So the first one here is about the governance and moving the process along, and the second one that was brought up as an example in a rural area is that with somebody need data analytics, where buying together would actually make more sense, wherever you fit into that conversation.
For us, we're usually the one clinic that doesn't fit with anybody. Doesn't fit anywhere.
So it would be that, because the OPCA staff now provides some level of support, not to the degree that you would need to get into total cost of care. And we work with OCHIN and other partners, to make sure that we're not duplicating resources and that kind of stuff. So there's a little bit of support on things like data transparency and trainings on how to take this data and use it and that sort of thing. But then to go to the next step would be a question of how to do that. But I would think that would be a separate question, but a very related question, depending on what organization it is.
For me, it's not even a platform really issue, because whatever platform you use, we're still going to struggle getting that information there from all of the sources that we have to pull from for us. So
maybe this is sort of an opportunity to kind of use your specialness as like sort of a scenario, better understand a scenario around, because I could imagine, and I don't have enough understanding, but just like doing sort of a case study around a subpopulation where maybe, so like youth, there could be potential for, the CCOs to care a lot about what the spend is on youth who are attributed to NARA.
Yeah,
so that's like sort of
we're trying to do a little bit of that. I think you know a little bit about the Care Oregon Care Coordination Project that we have going on with the tribes, and where with the open card folks in the state, because most of our folks are on open card, or are uninsured because natives choose to remain uninsured, or they flip back and forth between open, managed care, uninsured 3-4 times during the year. So that's part of the project with Care Oregon, that trying to collect that information so we can. I think we would benefit from this by just the learning knowledge that we could benefit, if anything.
The other benefit maybe is we're acting more and more like a network every year, which is really exciting. Take the cost and everything we're having out of that, but there's a lot of resources at the CCO level that could end up paying for like, analytics or for another platform if we go in another platform direction, and it may not be. So if we get together and act in a governance type of way, we may be able to ask, they got to figure out the legal ramifications of that, but maybe able to ask the CCOs for resourcing some of this. So, that may be the question.
We'd love to not be the unique person at the table.
Well, wouldn't it be part of the charge of the governance committee to plot out, a strategy that adds value across the membership, regardless of whether you are, Epic or, whatever other platform, or whether you're on Accurate, but there's some basic infrastructure kinds of things in how you use data and how you use that to think about cost of care and managing populations that seems to me transcend, some of the technical things.
That culture of data that Jeremy was talking about.
Right. Much like what has developed around APCM, where APM, whether you are participating in APM or not, there are things about some of the trainings and thinking around the model of care, which is actually beneficial for the entire network, whether you are you have that contract with the state or not. So it's like upping the game of the use of data and our sophistication for doing population health is really kind of the broader thing, and then this is just part of a strategy around that.
So are we hearing any comments from the virtual world? Any?
Yes, I'd like to make a comment.
Yes.
So, this year we've already integrated a brand new EMR. We're in the throes of integrating a new data warehouse as well, and so I expect others saying that to them this is a modest cost, but for us it's actually a pretty significant cost for something that I feel is somewhat of a duplication of what we're already doing, without any clear deliverables of what I could expect from it. And so I just want to voice that when I hear people talk about, forcing all, members to have to pay for this, that doesn't stir the happiest feelings inside of me.
I don't know who's speaking.
The question is who's speaking?
Huh? Nick? Seth. Oh, Seth.
Seth.
Oh.
Okay.
Good morning. Sorry.
Other people on the phone, we've had you muted for a couple minutes because of the hold music. So,
any other comments from the phone?
This is Blaine. None for me. I'm good.
So what I'm hearing is there's general acceptance for the recommendations. There's a question on the financing, how supported. There seems to be not unanimity, but a very high degree of consensus to move forward with the recommendation at the modest budget projection that was put on the table. And one of the questions remains, is that a general allocation to all of the membership, or is that just a subset are going to support the effort? I'm hearing that there's generally believe that there'll be value beyond just some of the short-term issues of the data warehouse, but the long-term capacity building and sharing that can come out of that. But that needs to be a board dialogue as part of this discussion.
Well, I would hope that there's more dialogue about the cost as well. I think that's what I'm trying to say here, is that I'm happy to do the initial moves here of looking at this. I'm not giving consensus to the cost that has been projected and how that's going to be allocated.
Well, I was going to add to that point that what we haven't talked about is the denominator. We've put a 32 clinic denominator in there, but we haven't talked about bigger clinics pay more, and so the smaller clinics with smaller budgets, because whatever the number is, $3,000 plus per clinic is a different hit if you look at it. We could talk about that, and so so when you were out of the room, we were talking about a board agenda item because if we're gonna run quickly, and the more I think about this, the more I want to pull that recommendation back off the table for two reasons. One, I think there needs to be more discussion with membership that haven't been on the table, and so maybe we need to think about, before making an assessment across all members, get a better idea of where people sit. So there's probably more than one set out there that may be thinking in that same area. So that's one thing. The other thing is I can meet with our accountant to see, because it's only a 2-month window with some holidays all over the place. Can we find in our budget a way to fund whatever that is going into January and then make the discussion? And I think we may be able to do that. So I just think it's premature. We got the board meeting this afternoon, and I don't feel like I'm going to have complete confidence that we'll have the right question answered with enough support from the members. And so that may be one way to handle it. And we absorb some costs from this. I think what we do is like any other association is we lower the costs as much as possible. We didn't fully fund Roger, and we didn't fund any of the additional staff time. And so we've done that before, I think. But when we get into the bigger decisions, a month or two here and a little bit here, because it hasn't been an expensive process to date, we can subsidize that to move things forward quickly, and we've done that in the past. When we get to bigger pocket decisions, I think we're going to have to act as a network in a way that we've funded up front, like other PCAs have done with their members when they get into bigger budget items, because there's going to be a certain amount where we're not going to fund, or our budget's going to be skinnier. Or
Craig, can I ask a point of clarification? Are you suggesting we hold on sort of executing with respect to that cost question, but maybe still consider, whether we're sort of agreeing to move forward with recommendations or not, just for clarity? In other words, starting the process of identifying, if assuming, and I think I'd like to make sure that we hear from anyone who hasn't had an opportunity to speak up, but I agree, I'm hearing mostly positive comments about accepting the recommendations, the cost piece potentially being separate. So
I think we go as far as we can on decision making on the recommendations and cost of this group as we can. And then we get out, because we figure out who hasn't been at the table talking, and do some homework, because this is a membership decision that the board's going to make. We only have half of our health centers on the board, so I want to make sure we do a little bit more work on that. But at the same time, to be clear, what we'd be funding is the steps going forward. So we're not going to sit on it for 2 months, but we got to figure out what resources we need over the next 2 months to carry out, a timeline that the governance committee would, help put into stone. So it's almost like act like we've got, because it sounds like people say this is valuable, cost may be an issue, let's start executing and figure out the parallel strategy of cost and decision making on the governance committee.
What I hear you saying, Craig, is that we don't know what that final dollar amount would be, or what the potential membership would be on a data warehouse or a data governance group, but we can work to that point over the next couple of months, and then we can make a decision at that point.
Yeah, that's right. Yeah.
Craig, this is Blaine. So the other thing I guess I wonder is how long are we, if we approve this, how long are we funding this for infinity, or is there a delineated time frame?
Oh, we're doing it in infinity, or ratcheting up 50% every 6 months. No, I think that's all for the governance. It's a 1-year decision. That's a 1-year budget, and so whenever that clock starts, like January to January, that's kind of what we're thinking of. And then the governance committee would work on it going forward.
And as part of the recommendations, it was suggested there be a disciplined annual review.
Right.
Do you want to continue or not? Yeah. Are you getting value out of the committee? And if not, then you disband.
Yeah.
And to William's point earlier, I think part of the upfront conversation in terms of the structure as well as how this is formulated as an exit strategy. I do recall in previous conversations there were some questions and open issues about, well, when the federal funds stop, or if we were to is that data, who owns that data? Who owns the expertise, if you will? And if we were to disengage entirely from Ocean, let's say, is there a goodbye fee?
And that's a classic example of something that the data committee would need to tackle.
Absolutely.
All right. Well, this ends my participation in the process. It's been an honor to support all of you over the last couple of months, and I think it's been very robust discussions. I think you should really applaud the members who participated. They had some really robust discussions and meaty conversations, and a lot of good sharing. So I applaud all of you for that work, and wish you best in this journey.
Thank you, Roger. Incredible work.
Any final comments in virtual world? So to close it all out, it's moving forward with recommending adoption of the recommendations to take to the board. In the meantime, the budget financing issues need to be discussed offline, talking to some of the members who haven't participated, educating them on what is proposed, and then bringing that to a head at the January board meeting.
I'd also like to thank Laura for picking up on this and fully. She's smiling, sort of like yes, and
just wait till she goes on about it.
That's right.
It was super fun.
Yeah.
I mean, I really couldn't have done it without Roger. Like, it's really, just can't thank you enough for developing a really robust and yet speedy process. I can't, when we talked about meeting this timeline, I can't believe that you accepted the charge, number one, and then that we
did it.
by and large did it. I'm really impressed. Forever grateful.
Right. Be careful when someone comes.
Good luck with your board meeting. Happy Thanksgiving.
Growth opportunity.